Hello and welcome to Prairie Pulse. Joining us on today's show is Dr. Thomas Haldus and Zeke Reynolds. Dr. Haldus is the Sanford Health Interventional Cardiologist, and of course, Zeke, you are the lead exercise physiologist.
Yes.
All right, I got all that out, so great. Here we go. Thanks for being with us today, guys.
Thank
we
you.
always start the show with, tell us a little bit about yourself and your background. And Zeke, let's start with you.
Sure. So I'm from Wisconsin originally, just south of La Crosse. I did my master's program there, where I got my degree in exercise physiology, and our program was geared towards cardiac rehab. My wife and I met in that program. We both ended up here at Sanford about 6 years ago and work under cardiac rehab currently.
Okay. Well, and Dr. Haldus, your background.
I'm originally from Philadelphia. I did all my training back east at a place called Geisinger Medical Center in Danville, Pennsylvania, and then right out of fellowship I came here back in 2005, and I've been with Sanford Merit Care ever since.
Okay. Well, Dr. Haldus, we're going to start with you, at least for the moment. I understand you're here to talk about coronary calcium screening. What is this?
Well, coronary calcium is, the screening itself it's a very rudimentary technology. So it's not anything new, it's not anything hot, you know, it's just basically a calcium, a CAT scan of your chest. And they take just ultra thin slices looking at the level of the coronary arteries, and they're looking for calcium. So calcium is the stuff in bones as you get older and develop atherosclerosis. Atherosclerosis is accompanied by some calcium, so it's a marker for atherosclerosis, and atherosclerosis is the disease that hardens arteries. So the scan itself is just looking for calcium in the coronary arteries. That's pretty much it, and it's a marker for atherosclerosis.
Okay, but what do you recommend patients do based on the screening?
Well, you know, if it depends on who goes into the screening. So the screening isn't for everybody. Like, you're not going to send a, 15-year-old guy into the screening center, looking for calcium. Likewise, you're not going to send, an 85-year-old person with previous coronary artery bypass grafting into the screening. It's mainly for those people sort of in the middle, those intermediate risk patients who might have, elevated cholesterol and they're not sure what to do with their lipid-lowering therapy. Might be somebody, like me, for example. My mother died at a young age, at age 60, and you start thinking, geez, do I have something brewing in there that I need to treat? So I go in and get a screen. So, things like that, people like that are ideal patients for this type of a screen. What you do with it once you're done, it depends on what the result is, and we can talk a little bit more about that as this talk goes on. But ultimately, you want to have a zero calcium. But the more calcium you've got, the more chances of severe atherosclerosis and blockages in the heart arteries you have.
Now, you say you want to have a zero calcium, but at certain ages, do people have at least some calcium buildup? I mean,
well, yeah, the older you get, you're going to wind up having some calcium at some point around those vessels. The best case is that you'd have none, but there's actually there's a continuum that goes on. So you're going to expect to see a little bit more calcium in a 75-year-old, but you don't want to see any in somebody who's in their 20s, 30s, or even low 40s.
Now, is this something new, this calcium screening, or you said it's not, so it's been going on?
This has been going on for years. In fact, I guess when I was back in medical school in the 90s, we were doing research at University of Pennsylvania looking at just this technology. It was called an electron beam CT to make it sound fancier, but ultimately what we did was we looked at calcium, and boy, we were screening everybody that came through this fellow's clinic, and just getting an idea of who has the calcium, what does it mean, how does it correlate with people's lipid levels, and then can we make changes.
Okay. Well, Zeke, let's come over to you. Well, actually, my first question is going to be, what does a lead, what did I state you were, a lead exercise physiologist do?
Sure. So our exercise physiologists primarily work in cardiac rehab after you've had some sort of procedure or had a MI or stroke or heart disease. At the screening center, I kind of oversee the day-to-day operations and then do patient care myself as far as screening patients.
Mm-hmm. So what is your role, I guess, in more detail in, preventing and treating heart disease in patients?
Exactly. So Since we're under the umbrella of cardiac rehab, it's kind of nice, and we have a good relationship with Dr. Haldis and the cardiology team. Our main goal is to identify patients who are at risk for heart disease, and if so, get them in touch with their primary care provider or cardiology. At that point, it's kind of from there, they would do some further investigation to see if they do have heart disease. If they do, then they might end up referring them back to cardiac rehab, where nurses or physiologists might work with them to kind of build back up their strength and talk to them about diet and exercise and get them back to normal life. So.
Well, you're also here today to talk about screening. Is there more than calcium screening? So what is the Sanford Center for Screening?
Yes, so the calcium scoring is one procedure we do as part of a heart screen. Patients will come in, we'll ask them some questions about their history. Family history, as Dr. Haldis touched on, is kind of a big risk factor as well. We look at diet and exercise, and then we check for different risk factors. So we'll get a height and weight, look at their body mass index, we'll check blood pressure, we'll do an EKG to look at their heart rate and rhythm. We'll check lipid levels, kind of their cholesterol, look at past levels of blood sugars. And then if they do have some risk factors for heart disease, we do that coronary calcium CT scan to identify those who may or may not be at higher risk for heart disease. And then we do have another screening that we do. It's a vascular screen, and that's a series of ultrasounds. So it's kind of everything else. They'll check the carotid arteries in the neck, abdominal aorta for aneurysms, and then the legs.
Okay. Do other hospitals or medical facilities do screenings like this?
You know, if you're not a Sanford patient, I'd recommend discussing it with like your primary care provider. They may, and I know some organizations come around to different communities and do some screenings as well. We take patients from not just Sanford, any hospital, and we're good about sending the information back to their hospital and making referrals that way.
Now, how do you work exercise into all of this?
So at the screening center, we kind of just do, talk to them about what they're doing for exercise. And then we give recommendations, we recommend 30 minutes a day, cardiovascular exercise, initiating some strength training and stretching, kind of just an overview of what we recommend. And then on the rehab side of things, in cardiac rehab, they actually work with patients. You come in for group exercise classes Monday, Wednesday, Friday, or Tuesday, Thursday, whatever works for you, to actually participate in exercise.
We probably know the answer to this question, but why don't people exercise enough?
I think it's, inconvenient. People come into the screening center and they have more excuses than I can account for why they don't have time to exercise. Really, it's about looking at your schedule and scheduling time that actually fits, and put it on a calendar so you actually, all right, this is my time to exercise. Because if you just say, well, I'll start an exercise program, you're going to find an excuse maybe not to do it. And then the other one that I look at is location. So if you live 20 minutes from your gym, the odds of you getting done with work at the end of the day and wanting to drive over there in negative 20-degree weather to exercise is a little lower. So I recommend finding something that's, convenient. If you make it convenient and take away as many barriers to exercise as you can, I think you'll be more successful in incorporating it.
Well, anyway, I can talk about all my excuses, and you're right on them. Dr. Haldis, we're going to come back to you. Let's talk about the advancements in combating heart disease over the years. How has that changed or improved?
Well, when you think about what's changed over the course of the last several years, coronary stents in themselves have become more advanced in that they have essentially anti-proliferative, meaning they're going to inhibit cell growth. So sometimes when you put a stent in back in the 90s, you'd wind up having scar tissue form inside the stent. Now that's actually inhibited, so the vessel stays open more often with stents. There's been refinements in coronary artery bypass grafting. There's been refinements in valve replacement technologies. So I mean, when you think about the mechanical aspect, the therapeutic aspect and procedural aspect of what we do, that's always advancing as things get smaller, things get essentially more technologically advanced in terms of what kind of chemical, and then better studies in terms of knowing what we're doing. On the medical side of things, you know, medications haven't changed terribly, you know, not very much over the past few years. You know, cholesterol lowering therapy is very similar to what it was, you know, when I finished medical school. Hypertensive management is very similar. What has changed, though, is there have been some injectables that have come out. And we don't have to talk about exact specifics, but what these do is they essentially bring your LDL cholesterol down to the level it was when you were essentially born. You know, we have this protein in our blood that causes degradation of LDL receptors in our liver. LDL is that bad particle in the blood that causes the blockages to form in the arteries. And those types of particles are not, they're not physiologic. Those particles do not need to be part of the blood or part of your body. So if we can find a way to inhibit those particles well, actually to lower the levels of those LDL particles in the blood, we can effectively reduce your risk of atherosclerosis.
Yeah, so why, it seems like there has been much more improvement in the heart area than it has in like battling cancer. Is there a reason for that?
I think it's just because there's more people that have, well, it's a very common disease. Heart disease is the #1 killer, so, you know, there's a lot of attention towards it. And, you know, just like, and, you know, I wouldn't put cancer down. There's been a lot of good advances with cancer medicine as well, too. They've really gotten into the immunotherapies, and there's been some really great therapies on the cancer side, but I can't speak to that specifically. But, you know, I'd say we're making great strides in both heart disease and cancer as far as I'm concerned.
Yeah. So let's go back to the heart disease. What are the warning signs of impending heart disease?
Well, you know, one of the most common causes of, say, a heart attack would be chest pain. But those symptoms can be different in different people. I generally look for, you know, has there been a change in your exercise level? You know, have you been, you know, say a year ago, are you doing the same amount of exercise that you were before? Say, you know, a year ago you went, you know, on your hunting trip with your buddy and you were able to walk up that hill. Now I have to stop halfway up the hill to get there. I've noticed a change. I get short of breath. I get fatigued. I get some chest pressure or chest pain. You know, those are the things that I'm looking for when I talk to people.
Okay. Well, we'll come back to more of that in a moment. But Zeke, coming back over to you, explain more about how you really get involved after someone has that heart issue, maybe sees Dr. Haldis and then all of a sudden is coming your way. So what happens then?
Sure. So after they've had a heart issue, they wouldn't go to the screening because we already know they have heart disease. But we would see them from the point of, you know, they have their intervention in the hospital. We see them typically that day even, oftentimes getting them up and walking right away that day if it allows. Otherwise the days after while you're in the hospital. And then we kind of focus on where you're from, find a cardiac rehab program in that area, whether it be Sanford or any of the other organizations. And then we put you in contact with them so that when you're discharged, you are already lined up with a program to go to for post-op care in cardiac rehab.
Okay. Well, Dr. Haldis, you know, there was a recent story that stated 50% of Americans have some sort of heart disease or impending heart disease. Seems high to me, although maybe it is. Can you just comment about heart disease? And I don't know if you know the report or not, but yeah.
Well, the report was lumping pretty much everything all together, you know, coronary disease, heart failure, even high blood pressure. So that is very common. I mean, if you think about the people in this room, you're going to wind up probably seeing, you know, maybe 40–50% have high blood pressure or have had a stent or have had some sort of an issue. You think about this coronary screening is we're getting better at detecting it early, so people find out a little bit earlier. So that's going to increase your population of people with heart disease as well.
Mm-hmm. Well, we're going to use me as an example. I guess, you know, 15, 16 months ago, Dr. Haldis, you know, but I had a heart attack. But I didn't have any symptoms leading up to it, at least that I recognized. And mine came on very quickly, and you did treat me. You just happened to be in the emergency room when I came through and put 2 stents in. Talk about, you know, a little bit about what we did and what we're doing to improve my health.
Well, you know, first we opened up the blocked vessel. So we want to preserve heart muscle. You've only got so much heart muscle, you don't want any of that to be damaged. So when somebody does have a heart attack, that means that there's some heart muscle cell death. So we don't want that to happen. We want to stop that in its tracks. So, you know, the goal here is to treat you fast. So if you start having symptoms of a heart attack, chest pain, things like that I told you about, you would want to come to the emergency room, and then once you come to the emergency room at any one of the medical centers in North Dakota, you're going to get treated very fast. You're going to be whisked off to the catheterization lab. There's going to be a whole team there. They're going to open up that artery. And the whole idea is to save heart muscle. Because the less, you know, when you have less heart muscle, when your ejection fraction, or the percentage that your heart works, is down, that does translate into a shortened life. That does affect that. So opening up the vessel is the first thing. After that's done, then we want to reduce your chances of having that heart attack again. So if you think about people who have had heart attacks, you know, who's at the greatest risk of having a heart attack? It's somebody who's had a heart attack before. So we treat you with strong antiplatelet agents. These are the sticky guys in the blood to prevent, you know, things from blocking up again. We treat you with the statin drugs, so the cholesterol-lowering medicines that we talked about a little bit. That's going to help prevent heart attacks. It also helps plaque regression if you get your levels down low enough. We treat blood pressure. We treat diabetes. You know, we want you to exercise, lose weight, be fit. So those are all things that are super important. The one thing you can't change your genetics. And the genetics of heart disease is very complex. It's not simple, you know, Mendelian genetics like blue eyes, brown eyes that we learned in school. There's like up to 150 different genetic markers now that they've found, I'm sure there's more, that contribute to your development of heart disease and subsequent, you know, heart attacks. Mm-hmm. So it's complicated.
Well, and I understand I may have been one of the lucky ones in that I did get treated very quickly. You've told me I had no heart damage, but that's not always the case. And I do take the pills that you mentioned now. So we are doing a number of those things. You've already told me what stents and what they do, but do you try to avoid open heart surgery more now than maybe in the past?
Well, I think we can avoid heart surgery, open heart surgery, more now than we did in the past because of the technological advancements with the stents. But there are guidelines that we follow. You know, there's you know, certain anatomic changes with the heart arteries that you see that just don't work well with stents. So if somebody needs heart surgery, they just need to get it, and it's a great option if you need it.
Mm-hmm. Well, Zeke, let's come back to you for a moment. What's the optimal exercise for a healthy heart, and when is the age best to start?
Sure. So the earlier the better. You know, you start exercising as early as possible, but as far as the right amount of exercise, you know, kind of a goal is 150 minutes a week. That's sort of just what's out there. You can break that down however it works best for you. So you could split it up into 30 minutes 5 days a week. You could do 45 minutes 3 days a week. Or you could split it up, you know, I'll do 15-minute walk this morning and I'll do another one at lunch, or, you know, one after work. You can split it up even further. So just some combination of cardiovascular, and then if you can do some weight-bearing strength exercises as well. You know, 3 days a week, that would be ideal.
So cardio is not everything for the heart.
It's very important for the heart, but you know, strength training from an overall health perspective is also very beneficial.
Yeah, but so what about how crucial is the diet and lifestyle choices?
So at the screening center, you know, when we get patients that come in that do have risk factors for heart disease, you know, the first thing we look at is diet and exercise. You know, what can you do to lower your risk factors? So the first thing we look at are the things you can control. Like Dr. Haldis said, you can't control genetics, but you can control diet, exercise, your weight to some extent, as far as controlling blood pressure and cholesterol as best you can that way. And then whatever we can't control with diet and exercise and lifestyle changes, then we start looking at medications and things like that.
Well, with that said, because I think about just me, use an example. I mean, when I was young, I was an athlete, and when I was in my teens, obviously very active, 20s pretty active. As I finally got a job, got a family, more of a sitting office job, it becomes hard and difficult to find those times to break the routine of life to take care of yourself, I guess is what I'm trying to say. Any more advice on that? I mean, you talk about just getting up and moving and walking at different times.
Well, that's the tough part is you know, athletes in high school, you know, you're used to eating a lot to support that athletic lifestyle. And then what happens? You know, you go to college, you finish college, you stop exercising, but the diet that supports that athletic lifestyle, you know, eating a ton, does not stop. And then all of a sudden you find yourself 50 pounds heavier, and it's very hard to get, you know, ahead of that once you do it.
Well, you talked about DNA, and you can't run away from genetics. I mean, that's there, and having good genetics play into probably this, or should people, do they need to get screened for that as well?
Well, the genomics of heart disease, like I said, is extraordinarily complicated. And no, there's not one genetic test that's going to give you an answer about whether or not you're going to develop heart disease. Your best clue to that is look at your family history, and that's what we use. You know, look at what your primary relatives are, your mom, dad, and your brothers and sisters. You know, uncles, aunts, grandfathers. That gives you like a little hint, but it doesn't really play out when you look at the statistics of development of heart disease. So I think, you know, if you have a question about whether or not you have heart disease, whether or not you have blockages in your heart arteries, if you're thinking something like that, then the screening center is an ideal answer for you. You go in and you get screened. Now then the question is, what does that even mean? If you wind up having an abnormal screen, or, you know, what does that do for a person? And this is very interesting data that just came out, and it was actually Christmas just this past 2018, and you know, somebody asked that question. They said, hey, what does this mean when somebody has, you know, a level of 0 versus 100 versus 200 versus 400 on your calcium screen? And what they found, and then what can we do about it? Does statin therapy really help? Those cholesterol lowering medicines that we prescribe everybody, does that really help? It turns out that if you do have a calcium score of, you know, 100 or 200 or 400, it dramatically reduces your risk of heart attacks, strokes, death over the course of 10 years. They looked at these people for like 10, 12 years. What was so fantastic about that study was not just that, but if your score was 0, it means statins did nothing for you. There was no benefit. So if you have 0 calcium, then you could argue you don't need to be on statin therapy. That's a big deal. But if you do have calcium, then you do need to be on something.
Okay. Well, I sat here reading some notes. It's heart attack, sometimes the symptoms are different between men and women. Can you talk a little bit about that, Dr. Hollis?
Sure. Women tend to have more atypical symptoms. You know, I've never been one of the people who said, oh, if it's not chest pressure right here radiating to your neck, then it's not your heart. You know, you look for any sort of exertional symptom. Exertional fatigue is a very generalized, you know, symptom. You know, feeling tired. I don't have the pep that I used to. There are different ways that people describe these symptoms. It's not a pain in my chest. It doesn't feel like a pain. It just feels like a pressure. Well, you know, pressure, you know, we say pain, but they say pressure. It's the same thing. Some people may have it in their arms. Some people may have it in their shoulders. Some people may have it in their back. Some people may have it in their belly. Generally, anything between your belly button and your eyeballs, I guess, is a legitimate, you know, site, you know, for a potential heart symptom. The key thing that I, you know, like to look at when you're looking at somebody who has, you know, potential heart disease and you think may have a symptom, what's happening when you exert yourself? So if this person is active and they're, you know, and they're regularly running up 3 flights of steps and they get that same symptom, well, that's a big clue to me that something's going on. The tough people are the ones where, you know, the most exercise they're doing is cracking open a bag of chips and sitting on the chair watching TV. You can't tell. So those are the ones that you're a little bit more aggressive with doing you know, functional testing, stress testing on.
Well, but of course, and how do you distinguish symptoms when you're overweight, And so climbing a flight of stairs might not put you out of breath, but you know, it's still, how can you distinguish the two?
You can't.
You can't.
You just, yeah, I mean, that's what makes it more difficult. That's why being heavy is a risk factor, because it masks things. It's just because I'm old, just because I'm a little overweight, you know, so you might miss it.
Yeah. Well, we're out of time, so thank you guys for joining us. But if people want more information, where can they go? Who can they contact?
Well, they would contact they would look on the Sanford Health website and just look for the Centers of Screening. Okay. Center of Screening, yeah.
Thanks again for joining us.
Thank you.
Well, that's all we have on Prairie Pulse for this week. And as always, thanks for watching.
Funding provided by the members of Prairie Public.